This is the second lecture of infant feeding. The objective of this lecture: formula feeding and types, weaning, first year feeding problems, overfeeding, regurgitation, colic, and constipation. Regarding formula feeding, most women make their feeding choices for their infant early in pregnancy. The usual intake to allow a weight gain of 25 to 30 grams per day will be 140 to 200 ml per kg per day in the first 3 months of life. But after that, the rate of weight gain declines. Vomiting and spitting up are common, and when weight gain and general well-being are noted, no change in formula is necessary. In addition to complementary food introduced at 6 months of age, continued breastfeeding or the use of infant formula for the entire first year of life should be encouraged. UNICEF estimates that a formula-fed child living in unclean condition is between 6 and 25 times more likely to die of diarrhea and 4 times more likely to die of pneumonia than breastfed child. Rarely use of powder infant formula has been associated with serious illness and even death due to infection with Coronabacter sakazaki and other microorganisms that can be introduced to power, powdered infant formula during its production. Although Coronabacter sakazaki can cause illness in all age groups, infants are believed to be at the greatest risk of infection. The WHO believes that such infections are underreported. Forms of infant formula. First, ready-to-feed cans do not need to be diluted with water. The formula can be poured directly into a bottle and refrigerated until use. This formula is the most convenient because no mixing or measuring is necessary. However, it is also the most expensive. Second, liquid concentrate formula is mixed with an equal amount of water. Then it is poured into the bottle and refrigerated until use. Third, powdered infant formula is mixed with water. 1 level scoop from can of the formula is added to each 2 ounces of water in a baby bottle. Do not pack the formula into the scoop or tap the side of the can before leaving off the scoop. Shake the bottle well to mix, refrigerate until ready to use. This type of formula is the least expensive. The types of powder infant formula. First, cow milk protein-based formula. The protein concentration varying from 1.45 to 1.6 gram per deciliter, considerably higher than in mature breast milk, which is about 1 gram per deciliter. The predominant whey protein is beta globulin in bovine milk and alpha lactoalbumin in human milk. A plant or a mixture of plant and animal oils are the source of fat in infant formula, provide 40 to 50% of the energy. Lactose is the major carbohydrate in mother's milk and in standard cow's milk based infant formula for term infants. Second, soy formulas free of cow's milk protein and lactose and provides 67 kilocalories per deciliter. The protein is a soy isolate supplemented with L-methionine, L-carnitine, and taurine to provide a protein content of 1.65 to 1.9 gram per deciliter. Indication: A. Infant with documented IgE-mediated cow milk protein allergy. B. Hereditary lactase deficiency or galactosemia. C. Situation in which vegetarian diet is preferred. 3. Protein hydrolyzed formula may be partially hydrolyzed containing oligopeptide with a molecular weight of less than 5,000 Dalton or extremely hydrolyzed containing peptide with a molecular weight of less than 3,000 Dalton. Indication: infant intolerant to cow milk or soy proteins, gastrointestinal malabsorption due to cystic fibrosis, short gut syndrome, and prolonged diarrhea. 4. Amino acid based formula are peptide free formula that contain a mixture of essential and non-essential amino acid. They are specifically designed for infants with dairy protein allergy who fail to thrive on extensively hydrolyzed protein formula. Whole cow milk is not recommended under 1 year of age because intolerance occurs, increased incidence of iron deficiency anemia, contains more solute that the kidney of small babies cannot cope with. Weaning. Weaning is the process of gradually introducing a mammal infant to what will be its adult diet and withdrawing the supply of its mother milk. When the best time to start weaning? The American Association of Pediatrics recommend exclusive breastfeeding for the first 6 months after birth and breastfeeding in combination with solid food until at least age 1. Extended breastfeeding is recommended as the mother and her baby wish to continue. Still, when to start weaning your child is a personal decision. Whenever the mother choose to start weaning her baby from the breast, stay focused on her child's need as well as her own. Resist comparing your situation with that of other families. Are there certain times when it wouldn't be smart to start weaning? Consider delaying weaning if concerned about allergen, might prevent or delay eczema, cow milk allergy, and wheezing in early childhood. The child isn't feeling well. If the child is ill or teething, postpone weaning until he or she is feeling better. A major change has occurred at home. Avoid initiating weaning during a time of major change at home. If the family has recently moved or the child care situation has changed, for example, postpone weaning until a less stressful time. What is the best way to begin weaning? When you start the weaning process, take it slow. Over the course of weeks or months, will cause milk supply to gradually diminish and prevent discomfort caused by engorgement, which is treated by applying cold compresses to the breast to help decrease swelling and discomfort. Keep in mind that children tend to be more attached to first and last feeding of the day when the need for comfort is greater. These feeding might be the last ones your child drops. As a result, it might be easier to drop a midday breastfeeding session first. After lunch of solid food, your child might become interested in an activity and naturally give up this session. Once you have successfully dropped one feeding, you can start working on dropping another. You might also choose to wean the baby from breast milk during the day but continue breastfeeding at night. Remember, it's up to the mom and her child. Important principle for weaning. Usually it is begin about 6 months of age. Avoid food with high allergenic potential. At the proper age, encourage a cup rather than a bottle. Introduce one food at a time. Energy density should exceed that of breast milk. Iron containing food, meat, iron supplemented cereals are required. Zinc intake should be encouraged with foods such as meat, dairy products, wheat, and rice. Phytate intake should be low to enhance mineral absorption. Breast milk should continue to 12-month formula or cow milk is then substituted. Fluid other than breast milk, formula, and water should be discouraged. First year feeding problems. Underfeeding, it is suggested by crying, restlessness, failure to gain weight adequately despite complete emptying of the breast of the bottle it, or the bottle. It is also a result from the failure to take sufficient quantities of food even when offered. The child will not gain weight, and actually he will lose weight and become marasmic, looks as an old man and lose the muscle bulk. Constipation, failure to sleep, irritability, and excessive crying are to be expected. The child will be deficient in vitamin A, B, C, D, iron deficiency, anemia, and protein deficiency also. Treatment of underfeeding include increasing nutrient intake, correcting any deficiencies of vitamin and or minerals, and instructing the caregiver in the art and the practice of infant feeding. If an underlying systemic disease, child abuse or neglect or psychological problems is responsible, specific management of that disorder is necessary. Overfeeding. Overfeeding means a baby is consuming more milk, breast milk, or infant formula than he needs for his growth and energy needs. Regurgitation and vomiting are the major symptoms. The symptoms associated with overfeeding are common mistakenly attributed to colic reflux, milk protein allergy, or intolerance or lactose intolerance. What separates overfeeding from these conditions is that the baby displays healthy growth. What are the complications of overfeeding baby? Chronic overfeeding can lead to overweight and obesity, makes acid reflux worse, vomiting. As we see, we have a prevalence of obesity which is high in our society. How to prevent overfeeding in babies? You may take the below steps to prevent overfeeding. First, breastfeed. The baby gets breast milk only when they suckle, which makes overfeeding almost impossible in such cases. Try paste bottle feeding. Paste bottle feeding is a method of controlling the flow of milk from the bottle. It is an excellent means to prevent overfeeding in an infant. 3. Maintain feeding schedule. Maintain a feeding schedule and the baby will adjust to it eventually. The baby then gets hungry at the same time each day and should be fed on time to avoid feeding more than usual between long intervals. Wait for the hunger cues. Look for signs and hunger like sucking at the fingers or moving their lips when touched gently. A baby who is hungry will latch on the nipple right away. Feed them only when they are hungry. Do not force baby to eat. If the baby is full, then do not force them to feed more, or you will end up overfeeding them. Vomiting and regurgitation. Vomiting is the forceful ejection of gastric content. Positing and regurgitation are terms used to describe the non-forceful return of milk but in different degree. Positing describe the small amount of milk which often accompany the return of swallowed air, whereas regurgitation describe frequent losses. Positing occur in nearly all babies from time to time, whereas regurgitation may indicate the presence of more significant gastroesophageal reflux. Common causes of vomiting in infant, which include gastroesophageal reflux, feeding problems, infection, and dietary protein intolerance, intestinal obstruction, inborn error metabolism, congenital adrenal hyperplasia, and renal failure, and many causes. Red flag, red flags about clinical features in the vomiting child. When we have bile stent vomitus, it indicates intestinal obstruction. When we have hematemesis, maybe esophagitis, peptic ulceration, oral or nasal bleeding. Projectile vomiting in the first weeks of life may indicate pyloric stenosis. Vomiting at the end of paroxysmal coughing, whooping cough, pertussis. Abdominal tenderness, abdominal pain, or on vomiting. Abdominal pain on movement. Abdominal distension, hepatosplenomegaly, blood in the stool, severe dehydration and shock, bulging fontanelle or seizure, failure to thrive. All of these are red flag when associated with vomiting. Colic. Definition: it is a complex of paroxysmal abdominal pain, presumably of intestinal origin. It is of unknown cause, but recent studies suggest that it has some relation to irritable bowel syndrome in adults of the same family. It is common in babies and called 3 months colic. There will be an unexplained irritability and severe crying. It occurs usually in the afternoon. Careful physical exam to exclude other causes of colic as interception, strangulated hernia, otitis media, pyelonephritis. Causes of infantile colic. It may include allergies, GERD, acid reflux, overstimulation, gas-producing foods, air intake from feeding or crying, immature digestive and nervous system. How to diagnose infantile colic? This is a very important subject. We are starting with Whistle's criteria, which is developed in 1954. They said or they mentioned episodes of inconsolable crying in an otherwise healthy infant, crying and or fussing for more than equal 3 hours per day, more than equal 3 days per week, more than equal 3 weeks. Then they developed modified Whistle's criteria in 1960s. Colicky infant cry constantly during the evening at about the same time each day in an otherwise healthy infant, crying and or fussing for more than equal 3 hours per day, more than equal 3 days per week, more than equal 1 week. Then they develop the Rome 3 criteria. It mentioned paroxysm of irritability, fussing or crying that start and stop without obvious cause, lasting more than equal 3 hours per day, more than equal 3 days per week, more than equal 1 week, with absence of failure to thrive in infant from birth to 4 months of age. This is developed at 2006. The last definition of infantile colic is Rome 4. What is new about it? It is Rome 3 plus after appropriate medical evaluation and symptoms cannot be attributed to any other condition, which is developed in 2016. Treatment. Holding the infant upright or prone across the lap or on a hot water bottle or heating pad occasionally helps. Passage of flatus or fecal material spontaneously or with expulsion of suppositories or enema sometimes afford relief. Carminative before feeding are ineffective in preventing the attacks. Sedation is occasionally indicated for a prolonged attack. If other measures fail, both the child and the parent may be sedated for a period. In extreme cases, temporary hospitalization of the infant, often with no more than change in the feeding routine, and a period of rest for the parent may help. Prevention of attacks should be sought by improving feeding technique, include burping, providing stable emotional environment, identifying possibly allergenic foods in the infant or nursing mother's diet, and avoiding underfeeding or overfeeding. Although it is not serious, colic can be particularly disturbing for the parents as well as infant. Thus, a supportive and sympathetic physician can be particularly helpful. Even if attacks do not resolve immediately, the fact that the condition rarely persists beyond 3 months of age should be reassuring. Constipation. Constipation is infrequent bowel movement or difficult passage of stools. Obstipation is intractable constipation. Constipation is particularly unknown in breastfed infant receiving an adequate amount of milk and is rare in formula-fed infant receiving an adequate intake. The consistency of the stool, not its frequency, is the basis for diagnosis. Must infant have one or more stools daily, but some occasionally have a stool of normal consistency at interval of up to 36 to 48 hours. Whenever constipation or obstipation is present from birth or shortly after birth, a rectal examination should be performed. Tight or spastic anal sphincter may occasionally be responsible for obstipation, and finger dilation is frequently corrective. Spastic anal sphincters may occasionally be responsible if irritation is alleviated. Healing usually occurs quickly. A ganglionic megacolon may be manifested by constipation in early infancy. The absence of stools in the rectum on digital examination suggests this possibility, but further diagnostic workup is indicated. Constipation may be caused by an insufficient amount of food or fluid, diets that are too high in protein or defic- deficient in bulk. Simply increasing the amount of fluid or sugar in the formula may be corrective during the first few months of life. After this age, better results are obtained by adding or increasing the intake of cereals, vegetables, and fruits. A prune juice, half to 1 ounce, may be helpful, but adding food with some bulk is usually more effective. Milk of magnesia may be given in a dose of 1 to 2 tablespoons, but should be reserved for unresponsive or severe constipation. Enema and suppositories should never be more than temporary measures. In summary, there are different types of formula feeding, which includes ordinary formula prepared for specific purpose. Weaning usually begins between 4 to 6 months. Underfeeding and overfeeding should be avoided. Differentiation between pathological from non-pathological throw up, colic in the first 3 months of life is very common non-pathological problem. Constipation should be managed properly. And thank you.